Stay tuned as On Call answers questions about breast surgery. Funding for On Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. A woman's breast is at once the origin of beauty and intimacy, provider of nourishment, and then, after all this, it can become a source for individual suffering requiring medical intervention. Motivations for breast surgery. The doctors are on call tonight.
Hello and welcome to On Call Television. It's wonderful that our ability to diagnose breast cancer early has been improving, and so has our ability to remove and treat these killing tumors. But it sometimes leaves the breast deformed or removed. It may be that the breasts are too large and uncomfortable and even disabling due to the extraordinary weight and size. It might be the other way around. Tonight, our topic is all about how we can now repair and reconstruct breasts to their original and or normal shape and consistency, or downsize to a manageable weight. With us tonight we have Dr. Teresa Wee, a surgeon at Brookings Health System, and Dr. Richard Howard, a surgeon with the Sioux Falls Center for Plastic and Reconstructive Surgery in Sioux Falls. Teresa, tell us a little bit about where you're from originally, and then where did you grow up?
Well, I actually am originally from Sisseton, up about 100 miles north of here, and then I did my undergrad at USD and did medical school there as well. After medical school, I went down to the University of Kansas in Wichita and did 5 years of general surgery residency there, and actually came back to Brookings after that.
Great. And your father's a physician?
He is. He's been doing general practice up in Sisseton for probably over 40 years now.
And he's still practicing?
He is. He's still practicing, just a few days a week and for a few hours to see those special patients of his.
All right, that's great. And Dr. Howard, Richard, you're plastic surgeons. You're originally from?
South of Lenox. Grew up on a farm south of Lenox. Went to high school there, undergraduate USD. I did my first 2 years of med school at USD, and I was one of that group time frame transferred to Milwaukee.
You and I were both in that. Where did you
Yeah.
transfer?
Medical College of Wisconsin in Milwaukee. And I graduated there. I did general surgery in Milwaukee at St. Joseph's Hospital, and then did plastic and reconstructive surgery at the University of Texas Medical Branch at Galveston, or UTMB for short.
Okay. And then you came back to South Dakota.
Bounced around a little bit, went to Sioux City, Iowa for a couple of years, went to Kansas City for about 10 months, and figured out I really didn't want to be in Kansas City.
And now you're not with any group.
No.
You're a single group. You plan on staying in your private practice by yourself without a group, or what's your plan?
January 2015, I'm going to get a partner.
Oh.
Junior, our son, is going to graduate from plastic and reconstructive surgery
No kidding.
residency, and he'll be joining us January 2015.
You call him Junior?
No.
You call him Richard.
It's going to be Son and Howard.
Oh, yes?
Yeah.
So, well, I imagine that is a thrill in a minute to have your family, your son
it's-
come home with.
Yeah. Best part, you get grandchildren come back, so.
Oh yeah, I
Super.
suppose. And where is he studying?
University of Oklahoma, Oklahoma City.
Great. So, and he grew up in Sioux Falls. Well,
Yes.
a variety of places.
Variety of places, but yeah, I did high school. I went to high school in Sioux Falls. He's an Augie Doggy,
Okay.
and USD School of Medicine.
So we have tonight 3 USD School of Medicine South Dakota kids.
Yeah.
Yeah. Well, it's great to have you here. And we're going to talk about the issues of reconstructive breast surgery. We can talk about breast cancer, other reasons for reconstruction of the breast. Breast is an important, of course, it's a very important issue, particularly, well, for the woman, for everybody in our society. And let's talk about breast cancer in particular and the diagnosis of breast cancer. I mean, that's not just a simple little thing anymore, Teresa.
No, breast cancer diagnosis, has changed with new imaging and advancements in imaging. Before it used to be plain films for mammography, and you weren't able to see as much. But now with digital films, they can see things that are a lot smaller. There's also ultrasound that augments the mammograms, and we can do breast MRIs, which can see very, very small lesions.
Now, there's a lot of debate about doing the breast MRI right off the bat, or how do you do that? I mean, what is the typical lineup?
The typical lineup is really doing, if you don't have anything that you can feel, screening mammograms are the first line for imaging of the breast. And then after that, diagnostic mammogram with ultrasound. And then if a cancer is diagnosed, a lot of times MRIs are done just to look for any other lesions that may be in the breast and may change the surgical plan.
So the MRI, though, shouldn't be the first thing done?
No, not yet necessarily. There are special cases, though, that MRI is done in, and that would be for somebody with a BRCA1 mutation or a BRCA2 mutation.
Okay, and that means that they have a genetic inheritance, BRCA1 and 2.
Yes. That's the breast cancer gene, also known as that. It puts people at much increased risk for breast cancer, and so then the screening regimen for them is to have a mammogram every year, but then yearly have an MRI, and then split those so that you actually have imaging every 6 months.
Ooh. Or just have the breast removed.
Right, or have prophylactic surgery.
At what time? At what age?
They try to wait until you're after childbearing, after you're done bearing all your children, because then you don't need to use your breast for lactation if you want to do that.
Okay. Is that an Angelina Jolie thing, or do you know?
I don't know.
You don't know that. Dick, do you know?
I think she was had
BRC.
a BRC mutation.
Okay. And the other issue is this. There was when do we start mammograms? I've been talking this whole week. I've been just blasted because I'm kind of following the national guidelines that says at 50, because if you start at 40, you have all these false positives, all these extra breast biopsies, all of this angst and cost, and very little people that are ending up with finding anything, but then every once in a while you do, right?
The age from 40 to 50 was kind of a recent change from the recommendations. And
I mean, it'd been 40 for a long time.
It'd been 40 for a long time, and in the last few years they changed it to 50. But there are a lot of cases that you find before the age of 50, and so my recommendations really are to start at 40.
For everybody. And I'd say, for me, I would say 50, unless there's a family history for cancer or you're nervous about it, you can choose. But the insurance companies may decide what that answer is on that one, too.
That's
check
true.
your plan. Richard, do you have any comments about that?
My practice is a little more skewed because I see the patients who are seeking reconstruction. They're generally younger in the demographic. So I frequently see patients coming in, went in, well, doc, I turned 40, decided to get a mammogram. Lo and behold, now I have a patient sitting there coming in for double mastectomies, reconstruction. But in my office, that's fairly common.
Yeah, there was this, apparently they were going to do a show on this on one of the morning shows, and a lady had it, I'm going to do the colonoscopy comparison to the classic story, and well, boy, she was in her late 30s,
Right.
and it was positive. So she's going forward with a lumpectomy.
That also just underscores the importance of doing self-breast exams starting at a young age, like 25, so that you know what your breasts feel like, and so that if there are any changes that you can catch it early, even before screening.
But there's some debate about that too, isn't there?
It's more, they're not recommending monthly breast exams anymore. They're recommending that you know what your breasts feel like, so that you can tell if there's any changes, which some people need to do it monthly, some people don't need to do it so often, apparently.
Oh, Richard, chime in.
I always ask the patients, are you doing your monthly self-exams? And it always amazes me, well, my breasts are lumpy and bumpy anyhow. And that's not the point. The point is, as Dr. Wee said, that an individual will know their body better than anybody else, so they're the first one who should pick up a change.
Yeah.
And that's what you're looking for, is a change. This wasn't there last month. What's going on?
Right. You know, there's a lot of things that statistics help us with. And we can be guided with the statistics, and we don't want to be over-guided, you know, in the direction of doing things because that's the way we've always done it and so on and so forth. But when they came out with don't do this, the statistics had suggested don't do self-breast exam. I thought to myself, I've had 5 cases of women who came in and found a breast cancer themselves, said, doctor, I found this is unusual. Got the mammogram, got the biopsy, breast cancer removed, self-breast exam was success. I mean, I've had cases. Have you had cases? You're young.
Yeah, I'm young. And so I haven't had that case yet, but I mean, in my residency, I've had that experience, absolutely.
Yeah.
I have to echo your response. Patients come in and another one that, and this is unusual, it's anecdotal, so I don't want anybody to think this is standard, but patient comes in, they're getting yearly mammograms and they're all negative, and then finds, you know, had a mammogram 6 months ago, and now there's a change, and then they go in and it goes back and forth. But the patient noticed a change, and that is, I think that's a critical thing to take home from this, is that if a woman notices a change, well, a woman that knows change in her breasts, or you notice, I mean, it goes anywhere. There's a change. Things shouldn't be changing.
No, I
Needs
have
to be
a case.
investigated.
I have had a case within the last 3 years, exactly that. Mammogram negative. I mean, they are just a test. I think we underestimate the value of the feeling that the person has, the self-sought thoughts about things, and the exam that the person has by themselves. So you both are totally in agreement with the idea of knowing your own breasts.
Oh, yeah.
Absolutely.
Being diagnosed with breast cancer can be a psychologically devastating event. Your world seems turned upside down. But every day, we get a little better at treating this terrible disease, and a life-affirming recovery is possible for many.
Mary Reed's world turned upside down 10 years ago. She was 38 years old. 9 months after a lump in her breast was initially diagnosed as benign, that same lump was determined to be cancerous. In 2003, she talked about when she first heard this diagnosis.
I remember getting in that car that day and driving out into Brookings, into the rest of the world, and just thinking that my life had just stopped, and I couldn't understand why the rest of the world was driving and shopping and in Hy-Vee and all over, and they know that I was just told I had cancer.
Today, Reed helps other women dealing with breast cancer by sharing her story.
I still get phone calls to this day from people newly diagnosed, and we will meet or we will visit. And the thing I want to say is everything is doable. It absolutely is not the end of your life. And I would be kidding you if I told you that when I was diagnosed, and especially when I found out the severity of the tumor and the nature and the pathology, I questioned how long I would still be here. It was big and it was aggressive.
The story that Reed tells is filled with the unexpected. She had no significant risk factors when she was diagnosed with an aggressive breast cancer at a young age. She found the cancerous lump herself. She had not even had her first mammogram yet. After a lumpectomy and grueling chemotherapy and radiation treatments for her cancer, she went on to have a prophylactic mastectomy. Surgeons removed all of her breast tissue from both sides of her chest to reduce the risk of further cancers. She then had breast reconstruction surgery and complications.
In fact, I had discovered myself some enlarged lymph nodes at the base of my neck. And being a nurse again, I knew enough to be a little concerned. I called my oncologist, and when he examined me and felt the lymph nodes above my collarbone, indeed, he just looked right at me and said, "Mary, the cancer is back." The biopsy, however, came back again and said, no, it was benign. Second time around. I have learned in my experience when to question and when to feel a little unsettled. When they told me the biopsy was benign, and yet I know what the PET scan looked like, it did not make me feel comfortable. I asked for a second opinion in Rochester, Minnesota at Mayo Clinic, and they happily sent me there.
At the Mayo Clinic, physicians finally determined that her cancer had not returned.
And after 3 days of scratching their heads and all new scans and another biopsy in Rochester, they decided that I had a silicone leak causing inflammation in all of those lymph nodes. And yes, on PET scan, for all of you out there that have had cancer and are getting PET scans, yes, your PET scan can look ugly at times of infection or inflammation.
Reed had new implants put in, a procedure that also had complications. Internal bleeding and emergency surgery followed. But Mary Reed perseveres, a classic example of a cancer survivor, actively working with physicians to fight her disease and trusting her intuition to lead the way.
Because I'm not a normal patient and I tend not to do things the normal way, I have a couple things that I think have saved me along the way. One is that little voice that I now always listen to, and I tell every woman and certainly everybody, please listen to that inner voice. It's there for a reason.
Boy, that inner voice. Thank you, Mary, for that. Mary, of course, is a dear friend of mine. She works in the OR. You both know her because she works in our operating room.
Yes.
And so what a thing to be able to say your story like that.
A thing about Mary is that, you know, I work with her 3 days a week, if not more, but she also does go and talk to breast cancer patients in the community, and actually further out than the community. She works for the American Cancer Society, and she gets calls from people who are diagnosed with breast cancer, and she tells them her story. She'll go to their house, show them her scars, and just, you know, make them feel at ease with this devastating diagnosis.
Right. And she had rather advanced level of cancer, and it's been cured. I mean, that's the other amazing thing that's happened through my lifetime, your lifetime too, Richard.
We're doing things now as far as reconstruction. I'm seeing patients for reconstruction now that have an excellent prognosis that when I was a resident, which 20 plus years ago, I didn't. And so there's been a tremendous improvement overall in survival and treatment.
A lot of that is radiation and surgical technique, but chemo is, I mean, having chemo doesn't mean, oh, well, I have to have chemo. That means, well, I'm not going to live a long time.
One of the things I think that I've seen and noticed is that, for instance, in surgery itself, when I was a resident, it went from that transition in general surgery of there was one operation. If a lady was diagnosed with breast cancer, everybody got the same.
The radical mastectomy.
Got the radical mastectomy. It didn't make a difference whether your tumor was the size of a pea or a tennis ball. They got the same surgery. And now the oncologic surgeons are tailoring the surgical procedures to provide the optimum surgical treatment in combination with the optimal chemotherapy if it's needed, and the endocrine therapy and the radiation therapy. So, and this is now being tailored for each individual patient on a much better basis than it used to be. Just everybody got the same thing.
One thing. I think that's it in all of medicine, though, isn't it? Really, every person is an individual, and their story is totally different. I mean, they may be compromised with heart failure, so you don't do this kind of therapy.
Right. Absolutely.
What about endocrine therapy? Now, what is endocrine therapy? Because you addressed one thing here that's...
Well, I can jump in on that. Endocrine therapy, that actually starts with the biopsy, because now we're doing core needle biopsies.
Core needle?
Which is a larger needle. It's about a 14 gauge, which...
Who knows what
Who knows, yeah. The needle that people draw your blood with is an 18 gauge. And so
it's a smaller.
that's
14
smaller.
is pretty big.
Yep,
Size
so
of a lead pencil, the lead.
basically, that tip, I show the people the end of my pen and say, without the pen out, that's what the size of a 14 gauge is.
So it's that hole at the end of a pen without the pen out. It's that hole. Okay.
So we get a larger sample, and they can run more tests on the sample, and they can tell you what receptors the breast cancer has. And the things that they look for more are estrogen, progesterone, and then HER2/neu. Those are the three things that we look for.
All right, so let's talk about receptors. I mean, that means it's a type of a tumor, and whether it responds to it responds to if you give estrogen or you don't give it. If you block estrogen, you give progesterone. You block progesterone. You give what's HER2.
HER2/neu, that can what they treat it with is Herceptin, which is a monoclonal antibody.
Okay.
So it's a specific chemotherapy that they use.
So if you have a particular response to the HER2 receptor, then you can get a certain type of chemotherapy that's very powerful and very effective for you. So that's important information that you do. That's endocrine information.
And has little toxicity.
Exactly.
Right, so I mean, you can get it, your hair doesn't fall out,
Correct.
You're not sick, you don't have nausea, and
results
and the
of
cancer
that,
goes away.
For the patients that have that, the results are, to me, nothing short of phenomenal. Because when I first learned about that, and I'm not too far out of residency, and I see a patient that I'm going through a thing, this lady should not be here now. I find out she's getting Herceptin, on a every 2 to 3 week basis, and long-term survivor.
Right, the cancer spread to the bone, and spread to the nose, it spread to the lung, and it goes away, and they live a normal life.
Right.
Yep.
Well, that's why triple negative cancers are bad cancers, because triple negative means that they don't have any of those receptors. And then they don't have anything that they can provide long-term treatment with.
Right.
With people who have estrogen and progesterone receptors, they're on anti-estrogens for 5 years afterwards.
Right. So let's talk about that 23% number that was flashed up on the screen after Mary's interview. 23% of the people who've had a breast cancer surgery have reconstruction surgery. Now, I've heard people say that that's way too small. I mean, that there are many people who could have breast reconstruction surgery but don't. And what's your take on that?
I think that everybody who wants to have reconstruction should have reconstruction. However, I do wonder if that number involves anybody who has lumpectomy, because sometimes can be an oncoplastic procedure itself.
I mean, in other words, it doesn't matter. I mean, you don't see it. You took a little lump out, and the breasts are virtually unchanged.
Right.
Richard.
It's really a personal choice for the patient. The options are there. Here's an anecdotal story for you.
Yeah.
So one of my first patients out of residency, 44 years old, who had breast cancer, mastectomy, chemotherapy, comes into the office, and I did a mastectomy and a contralateral prophylactic mastectomy. So now she's bilateral mastectomies, bilateral reconstruction.
Bilateral, I mean, both breasts are gone.
Both breasts are gone. Now, this is all done in stages, so from start to, bilateral reconstruction, we put in tissue expanders, do a tissue expander, put a permanent implant in, because you need to create a pocket, and then you put a permanent implant in, and then did a nipple reconstruction. Start to finish was 10 months.
Right.
And I got this secondhand, but a friend of hers asked her, says, well, why did you, after everything you went through, the mastectomy, the chemotherapy, all that, why did you do this? Why did you subject yourself to another basically year of this? And her response was, when I step out of the shower in the morning and I'm drying off with a towel and I turn and look in the mirror, I'm not getting slapped upside the head with a 2x4 every day. So now I'm just normal. And for her, that was extreme. The whole process was extremely important just for that.
So before, she had large breasts then?
Yes.
Oh, but you mean slapped by this head?
Oh no! I mean, it was this. It was a visual impact of seeing a
No breast.
mastectomy, and one breast gone and a large breast on the other side. And it's just.
It's important.
It's a raw wound, and
Yeah.
every day she looked in the mirror, and it's just opened up again.
And I need to talk a little bit more about what you said, and we've got to go to a break, but all of this tissue expanding and all of these things, how close does it look like normal? And, you know, we need to talk about that. And so we'll get back to it in just a minute. Doctors, technicians, and nurses from a variety of disciplines meet together on the Avera campus each week to share their expertise for the latest cases of breast cancer entering the hospital. They look for the most effective and least invasive processes to help each patient.
We see cases, we saw this morning, cases of breast cancer that were found early, and sometimes very early, only a few millimeters, on screening mammograms. A woman comes in, we find the breast cancer, we find it before it's metastasized, before it's going to end her life, when it's easily treated, and we find it on a regular basis. And nationally, internationally as well, it's been proven over and over again that breast screening with mammograms, physical exam, do catch cancers earlier, and there's greater than 30% reduction in mortality from breast cancer with screening mammograms. It's been approximately meeting 2 years, and basically it is the pathologists, the radiologists, plastic surgeons, breast surgeons, radiation oncology, medical oncology, as well as a number of support services, nurses, and technologists that all meet and discuss every new case of breast cancer that comes to the Avera campus. One of the main purposes of the meeting, determining what kind of operation is going to be most effective for the person, for the woman involved, and also least invasive. For example, if a woman is eligible for a lumpectomy and it is in her best interest, we would definitely urge her to have the lumpectomy and have a small portion of her breast removed rather than having a mastectomy and the entire breast removed, especially when we know that long-term outcome and survival will be the same. We want to preserve the woman as much as possible. And it depends on what the woman wants. And so that's the other thing. The women aren't present at the meeting, but the women have met with different physicians and expressed concerns or expressed what their desires for treatment are, and then that is taken into account. Today we had 12 cases of breast cancer, very different presentations and different choices as far as, especially now, there's all different choices with different kinds of radiation, different methods of delivery of radiation, different kinds of chemotherapy, as well as different ways in which to evaluate the breast tissue and follow and determine whether or not the cancer has metastasized or not. Deals also with the nature of the disease, with the pathologist evaluating and reevaluating the different kinds of breast cancer that there are, the different receptor hormones that are involved in that breast cancer, which also helps the pathologist, it helps the medical oncologist. The pathologist also helps the surgeon in determining the margin status, meaning if the entire cancer was removed and how much of a margin is there around the cancer to ensure that that cancer will not come back.
So it's very interesting that Dr. Alpers talked about this breast weekly meeting or about, do you guys attend? You're in Sioux Falls. Do you go to this meeting?
Almost every week.
And you're in Brookings. And do you go to this meeting?
Anytime that I have a breast cancer patient, I teleconference in. And
So you're involved with every
they're
case that is
involved.
your patient.
yeah, absolutely. And I listen to all the rest of the cases that they present that week as well.
So you both go to the same conference. And the issue, and you do work together. Tell me a little bit about how you work together.
Well, Dr. Howard has been gracious enough to come up to Brookings and help me out with breast cancer cases I've had. Some of them, they want to go forward with bilateral mastectomies and
Both sides,
Both sides.
breast removed.
breast removed, and we can offer them immediate reconstruction, stage 1 reconstruction here in Brookings.
Stage 1 meaning?
Well, Dr. Wee would do the mastectomy portion, and it's like tag team. So I'm there waiting. She completes her portion. The patient remains under anesthesia, new drapes and instruments, and then we come in and put in, the first stage is a tissue expander, and that is an implant that's specially designed. It goes underneath, generally underneath the muscle, close up the incisions, and then after about 10 days or so, you can start accessing this tissue expander, which goes in flat. There's a port that we can find through the skin, and then place a small needle through the skin into the port, and then you can inject that with some saline, and you do that once a week. And here it works out very nicely because we tag team and we do that part and put in the tissue expander, close up everything. Dr. Wee follows up the patient, their drain tubes in, they come out, and she starts doing the expansions. And then I'm up here once a month, so then I'll see the patient once a month, and then in the meantime, she's doing the expansions in her office. So their time frame, the reconstruction just progresses very nicely.
So it's basically a balloon that blows up a little bit more, and the tissue gets, and the skin stretches, and the tissue gets better and ready.
Just like the abdomen does during pregnancy.
Yep.
That gradual stretching. And then it gets to a certain level, and then you put an implant in.
We expand it, and rule of thumb is it takes 3 months to expand, and then you need to let it rest for 3 months because there's a reaction on the inside around this expander. Let it rest and settle down or mature for 3 months, and then take out the tissue expander as second operation. Take out the tissue expander, put a permanent implant in. And you need to do that because the tissue expanders are designed to expand, and they look pretty much like a soup bowl underneath the skin. They're kind of rock hard. I tell folks just family reunions are going to be kind of tough because
You're going to hug people, and they're going to go, ooh.
yeah, you're gonna break their ribs.
Yes. So not just hug lightly.
Just hug lightly.
So, but there is, and do you know how much to put in? I mean, how do you know?
The final amount is directed by Dr. Howard, but we usually try to do about 60 milliliters or 60 cc's a week, and
That's about how much? That's a half a cup?
it's about, how many is that?
60?
Not quite half a cup.
Yeah.
Yeah, all right.
But what we try to do is, while I'm doing that, I take a look at the skin, make sure that it's not getting too tight, that the patient's not having any pain, that the blood flow to the skin is still good.
Right, so that's the issue. And then, okay, people are concerned about, I mean, there's 23% that have breast reconstruction after surgery, but my guess is that there are people who don't have it because they're concerned about the problems that people have had with breast augmentation. I mean, there's all these stories about rheumatoid arthritis that follows it, and they rupture, and all of the problems that can occur with breast implants. What's your take on that, Richard?
Well, definitely implants have changed over the course of time. This whole concern came about probably about 1990, and the manufacturers were trying to make the breast implants softer, so they made them thinner. The gel was thinner, it's more like water, but the rupture rate was fairly high. Back then it wasn't considered to be a big issue. But there were concerns that the free silicone, if the implant ruptures, you got silicone in there, it was toxic, somehow it was going to trigger the body to have an immune reaction, and then patients might develop diseases like rheumatoid arthritis or lupus or scleroderma.
Right.
And these are terrible diseases. We
Right.
don't really know what causes them. You can't cure them, and treatment sometimes doesn't work. So basically there's a worldwide moratorium on silicone gel breast implants.
That was 1992.
2. And the United States and Canada, the last 2 countries in the world to approve silicone gel implants, which they did in December 2006. But basically from 1992 until 2006, literally worldwide, thousands upon thousands of studies were done looking at silicone gel, its effects on the human body. And basically FDA came up in 2006 and said, we've looked at all this stuff and we can find no link between silicone gel and these diseases. So they approved the implants across the board for reconstruction and for breast augmentation. There's a lot of extra paperwork now involved, but and of course, like any mechanical device, they can fail. There are problems, but the FDA is always looking at what's the balance between risk and benefits,
Right.
and that's what they decide. The benefits outweighed the risks.
And they're better now than they were in '92. I mean, are they're thicker walls, or they're less thin?
A couple of things. The shells are multi-layered now, so the shells are silicone rubber and the contents is a silicone gel. The gel now is called cohesive, so it's, instead of being a liquid, it's more like a gummy bear candy. Not truly a gummy bear, but they're more like that.
Yeah, okay. Any comments about all that with you? That's his
Not
territory.
really. That's
his area.
definitely his area.
But you would recommend it. I mean, if a person was concerned about coming out of the shower and looking at themselves in the mirror.
Absolutely. I've had a patient that was actually on the table for a different surgery. She had colon cancer and she had a liver lesion, so we need to resect part of her liver. On the table, I kind of looked at her breasts and I saw some scars, and I thought, she doesn't look like she's had a breast implant. You know, she had breast cancer in the past. She had had bilateral mastectomies. I could not tell just looking that she had had breast reconstructive surgery. That's how good breast reconstructive surgery has gotten.
So one of the things that you talked with me earlier about is symmetry. Mm-hmm. And so let's talk a little bit about that. Comments about symmetry.
Well, symmetry, you know, for patients who undergo surgery for cancer, whether it's a lumpectomy or it's a mastectomy, surgery for symmetry doesn't always mean that you have another breast. Some people request that the other breast be taken off so that they're symmetric.
Right.
Sometimes with lumpectomy, we can do a reduction on the one side so that we remove a certain amount of tissue and their breast is smaller. This is for large-breasted women. But then Dr. Howard could come in and do a reduction on the other side to make them symmetric.
And there's a lot of breast reduction surgery that could or should do, I mean, because of the...
Well, I mean, just breast reduction is a big part of my practice. And these are ladies with large breasts, double Ds and larger, that are I mean, just the act of carrying this extra weight around is causing a physical toll in their bodies. They're having back and shoulder pain and discomfort, and it finally gets to the point where they can't do it anymore.
I mean, the bra straps that I have in some patients that are inches deep from carrying on that burden their life. Quite a significant thing. Well, post-mastectomy decisions are highly personal and individualized for each woman. For women who do not choose to have reconstructive surgery, there are alternative products among which to choose.
There's some women who want reconstructive surgery. There's some that want to go the natural route and have just none. And there's some women that want to have forms like this to match their other breast. We offer form fittings that are made out of silicone, which are these right here. And then we have bras or regular bras, just like all the other ones. But these ones have pockets inside of them. During the fitting, I will measure you, and then we'll measure what cup size you need. And then we'll measure the form, and then we'll go through the bras and they pick out what kind and what color, and then we'll try them on. It's usually about a half hour to 45 minutes, however long it takes, as long as they're comfortable. If people have a lumpectomy, then we have these silicone, and they feel like natural breasts, and they can go in. We also have women who's had one breast that's been removed, so then we have these ones, and then For double mastectomy, it's for the same thing. And like I said, it's just the size and preference of what feels more comfortable. We do have some that in the pockets of our bras, you slide the breast in, but we also do have some that some women like in their contact ones, and they just go right on your skin. They're just natural bras that look like every other bra. The only difference is from this one is just you have a little pocket. I will take the form and I'll fold it over a little bit, and we're going to go through this little hole here. Some women like when you put the breast in when they're wearing the bra. Some feel more comfortable when you put it in before you put the bra on them. So then it just looks like that. We do try to make it an experience to where they're comfortable, because they do come first. And so it doesn't matter if it's how long the appointment lasts, as long as they feel comfortable. And then, they look in the mirror, and as long as you see a smile, then you know that everything is just perfect.
Wow, I 1882 for surgery. I'd ask your response to that particular story, Halsted's famous first mastectomy. They did it with anesthesia, of course.
Well, I would just say that things have changed a lot since 1882, and even in the last 20, 30 years, they've changed quite a bit.
Right, there were old radical mastectomies, and I still have patients who've had them. Mm-hmm. They tell me about the surgery. What would they do?
They would. I've never done a radical mastectomy. I've done modified radicals, but what they've done they would remove the entire breast tissue as well as the pectoralis muscle, correct?
Yes.
And all the lymph nodes.
And then the result is the drainage from the left arm or the right arm, whichever breast it was removed. I don't know why I said left. I'm thinking heart. I'm a heart guy. Would swell. I mean, they'd have all sorts of lymphedema and problems that way. Do people with any of these kinds of procedures nowadays still have lymphedema? I guess what
Not very common. You occasionally will see that, but I don't think I've seen anybody who had, say, a mastectomy and a sentinel node. But if they go, I mean, even today, going in and doing an axillary dissection, when I trained in general surgery, when you got done with the axillary dissection, it was like a 3 or 4 hour operation, and it was, I mean, there was nothing left in the armpit but the blood vessels, and you got 40, 50 lymph nodes out. Now they just, you only have to do about 10 or 15.
So it's a lot better. The sentinel node, tell me, what does that mean?
Well, sentinel lymph node is what you do is you use tracers to try to find which lymph nodes drain the breast first. And usually that means removing 1 to 4 lymph nodes versus the 10 to 15 of doing a...
We've got a staging picture that we'd like to go to, so explain that again. So you inject a dye and that you can see where it goes?
It used to be a dye. Sometimes that's still used, but there's also a radioactive tracer actually that we use a little probe and are able to figure out how hot the node is. The node that's the hottest, we will remove that one and then take a look inside the armpit and look for any nodes that are 10% of that or more, and remove those as well.
All right. So you're removing the ones that would have the higher risk of having cancer in them.
Yes, because they're the ones that first drain that breast.
So how long has that technique been around? 10 years?
Probably about 10.
So it's
targeted technology.
Yeah.
Just doing the optimum surgery.
Right. Yeah. Going right after and not ending up with this huge drainage thing. Reconstructive breast surgery in general, that isn't just post-cancer, though. I mean, following cancer. It's what other things that would bring a person to have their breasts reconstructed?
Congenital anomalies, such as Poland syndrome, where basically one breast doesn't develop, and it can range anywhere from a significant asymmetry of the breast. So a lady may have a C cup on one side and an A cup on the other side. There's different degrees of what we call penetrance of this syndrome. And in some cases, the pectoralis muscle will be gone, the breast will be gone, and even the nipple will be gone. I haven't
Wow.
seen that personally, but we get about 1 or 2 a year where normal breast and basically just have skin and a nipple on the other side. So there's a reason to do a reconstruction there as well. Haven't seen this since I was in training, but patients with extensive burns. Now we're talking about girls that were in major burns, house fires, for example, when they were very, very young, just toddlers or younger, or some type of terrible accident. And they'll have scar tissue, we're talking 80, 90% burns, scar tissue surrounding their chest. When the breasts start to develop, they cannot develop because the scar will hold them in, and then you need to do some surgical procedures just to release the scar so the breast can develop normally.
And what about the people who have large breasts? I mean, let's talk about reduction mammoplasty. Isn't that what it's called, or whatever it's called? I mean, there are a lot of people who are burdened by that, and we talked about it earlier. How is that done?
Well, there's a couple different ways. One, you preserve the nipple
Right.
attached to the breast tissue.
Right.
And another one for ladies with very, very large breasts, you actually take the nipple totally off and set it aside, wrapped up in a little saline gauze. I tell folks just like moving sod.
Yes.
Then you do a reduction and you've marked where it's supposed to go. You remove the skin, you take the nipple, defat it or make it thinner, and you put it back on. Sew it down and wait for a week before you look at it.
Okay, and hope that it takes.
And 95% of the time they do.
Yeah. Now, there are times that you remove the nipple, and people have tattoos and stuff like that.
For reconstruction, yes.
Yeah.
Most breast surgery, we still remove the nipple if we do a mastectomy. There have been times that people keep their nipple, but I think it's maybe going towards that now.
Seeing a few, but they're, again, targeted therapy for an individual, because not everyone's going to be a candidate for that.
So now a lot of people don't get mastectomies, they get lumpectomies and radiation. Explain that a little bit, Teresa.
Lumpectomy and radiation means removing just a small portion of the breast with the cancer in it. There are certain people who aren't candidates for it, but many people are, especially with diagnosing breast cancer at such an early stage nowadays. Yep. The thing about lumpectomy is that you need to have radiation with it to make it comparable to mastectomy.
Right. So, and there are certain kinds of cancer that if you find it, it looks like the kind that you have to do the other breast too. I mean, explain that, where you see this kind of cancer, you know that it's in the other side.
Well, there's lobular cancer,
right,
which is different than ductal cancer. Ductal cancer is the most common type of breast cancer. Lobular, we have ducts and lobules. If we go to picture
milk.
2.
Okay, picture 2. Let's go. So go on.
There's lobules and ducts. And so ducts are what carry the milk to the nipple. Ductal cancer is the most common. Lobular cancer is there as well, and that you have an increased risk of breast cancer on the other side. You don't necessarily have breast cancer on the other side, but it does make having a bilateral mastectomy more reasonable.
So anything from the picture that you need to say, the lobules that makes the milk?
Yes,
okay.
Lobules make the milk.
And the gland is the duct carry it. All right. And there's flaps that we can do when we're doing reconstruction. Tell me a little bit about that. Very quickly.
Flap reconstruction involves moving skin and muscle and fat from somewhere in the body to the chest to do a breast reconstruction. It used to be more common because of the controversy about silicone gel implants. More commonly now we're doing implant reconstruction because of skin-sparing mastectomies per the oncologic surgeons, allow us to do better reconstructive surgery. But there are still instances where
you can do a flap.
A flap is going to be preferred. And you can bring a flap from the abdomen, called a tram flap. You can bring a flap from the back, called the latissimus dorsi flap.
Great. So there's good. Well, we've got another coming, so we'll be right back after this.
You want your baby to have the best possible start to a healthy life. Using the new Safe Sleep Guidelines can help. Babies sleep safest on their backs, on a firm surface, alone.
My grandchildren, Henry and Stella, are a joy. There's never a dull moment. But at nap time and at bedtime, we make sure that there are no toys, pillows, or blankets with them when they sleep.
Every sleep time counts. Learn more. For baby's sake.
Why does the female breast get so much attention? Why has the female organ, which has evolved there to feed her newborn child, become Madison Avenue's surefire way to sell almost anything to men and women? Is it because the infant memory most of us have of the calming, unconditional, caring nature of mama and of the nutritious and life-sustaining milk coming from her breast? Or is it because breasts are usually covered or partly hidden from public view? Is it the fact breasts are forbidden fruit and it's the social allure of the taboo that has made them so interesting? Jerry Seinfeld said that if women kept their heads covered instead of their breasts, we'd all be heading down to the corner store to pick up the latest copy of Heads Illustrated. I think the answer to our question runs deeper than juvenile musings or the appeal of a prohibited peak. Evolutionary psychologists speculate that breasts are what attracted ancestral males seeking a healthy partner with whom to make children. It's therefore no surprise that the human female is the only primate that possesses fully formed breasts even when not pregnant. Is it also because of breasts that humans are the only mammals that mate in the frontal facing each other more interactive manner? And is it true what anthropologists suggest, that the consequences of that female to male, face-to-face, caring to competitive interaction that has led to a more compassionate and just nature of our societies, allowing for social progress instead of war? And yet with all this interest, the breast can turn cancerous and become a source for fear, loss, and suffering. It is appropriate and even glorious that we have advanced our medical and surgical knowledge to discover breast malignancy, to remove the destructive tumors, and to repair and reconstruct the breasts back to their original shape and consistency. Think how devastating to lose them and not to be able to get them back. A woman's breast is at once the origin of intimacy, the nourishing gift of mother's milk, and perhaps the foundation for civilization. And then, after all this nurturing, to become such a potential source for individual suffering. No wonder breasts get all that attention. They deserve it. Well, that was a little. Somebody said I practiced on a few people. My friends rolled their eyes. The women were a bit embarrassed. The guy said, "That's right on the mark." Comments, Teresa.
The basis of civilization.
Yeah, was that a stretch?
It may have been a little stretch, but maybe not. I don't know.
I mean, you think about it. The women do soften the guy. The natural process. Men would be off to war if it weren't for the fact that we are oftentimes together. Richard?
Well, the ladies I see that come in for reconstruction, this is part of their whole psyche. Whether it's a making them feel complete as a woman, or making them, it's closure on completing the treatment for the cancer. I tell ladies that come in many times, I said, this is going to be a bad year, but next year will be better. And more than once they've come back and said, you were right. It was a bad year, but this year's a lot better. For whatever reason it is, you are correct. It is a highly motivated, moving force throughout all society, medicine, everything. And I think the reasons for reconstruction are just as varied as the people who come in seeking it.
Right on the mark. Well, this brings us to the end of our show this evening. I sincerely thank our guests, Dr. Teresa Wee, Dr. Richard Howard, for providing insight for our audience tonight. In King Lear, William Shakespeare wrote, "Infirmity doth still neglect all office, whereto our health is bound. We are not ourselves, when nature, being oppressed, commands the mind to suffer with the body." Until next time, stay healthy out there, people.
Funding for On-Call Television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support the On-Call Television as it continues to open doors for important medical information, and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by Dakota Care, the Brookings Health System, myself with Dakota Allergy and Asthma, Dakota Dermatology, Dr. Lazier and Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftell Communications.
Closed captioning for On-Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.